Okay, okay. We are on live.
So, good evening, delegates. Good evening, Dr. Snehal Kohale, our speaker. So, I welcome you all to this session. I am Dr. Maunika, medical advisor from Shield Healthcare. So, before starting this session, I would like to give a brief introduction regarding our Shield Connect page. Shield Connect page is basically a knowledge sharing platform where various information regarding gynecology and pediatrics has been shared here, and various doctors from the overall India have been connected with us. We have even block section where individually, depending on the disease, different blocks have been uploaded here. You can find out new information. Various awareness programs are there for better knowledge upgradation. You can just follow the Shield Connect page. And today's session is regarding strategies to cope up with this decreasing AMH in infertility by Dr. Snehal Kohale. I welcome you, ma'am, for today's session. She is MBBS, MS, DNB, OBGYN, MRC, OG, UK, Fellowship in Reproductive Medicine, Clinical Director and Consultant Fertility Specialist at OVA Fertility and Women Care, Thane. I hand over the session to you, ma'am.
Okay, thank you. Thank you so much for kind introduction. I'll just share my screen. Yeah, is it visible?
Yes,
yes, ma'am, it is visible.
Okay. And I suppose, is it a full screen?
Yes, ma'am.
Yes,
yeah. Okay. So hello, very good evening to everyone, and wish you all very happy Diwali on this Diwali Eve. I'm so glad to discuss this topic, strategies to cope up with decreasing AMH in infertility cases. And yes, of course, I would like to have this as an interactive session, definitely, because we'll be discussing few points. And I have tried to keep it very much practical, which is more, which will be more helpful for the clinicians in their daily routine practice. And I would encourage during the session, first we'll discuss in details, like nowadays, how there is an overall decline in the fertility, and overall now majority of the patients, what we see in the routine, overall, of course, the infertility rates are higher, but in that, the patients with a low AMH, we are finding it more often. And nowadays, with in the background of the current ART law, where the donor eggs availability is again little difficult. So in all these backgrounds, we are discussing this topic, like how best we can give it to our patients and what strategies we can use so that they can utilize their own eggs, they can have their own biological child. Okay, so I would encourage to write down the questions. In between also we can take it, or at the end of the session, I would really encourage the interactive sessions. Okay, so we'll go ahead with our this thing. Just a second. Okay. Yeah. Okay. I think just a second. I'll share one more time. There's some. Yeah. Yeah. So as I was discussing, there is an overall decreasing fertility potential all over the world. So infertility affecting as many as 186 million people worldwide, with significant medical, psychological, and economic implications. At any point in time, almost 10 to 15% couples are expected to be facing some kind of fertility-related issues. And approximately 40 to 50% of infertility cases involve female factors. And of course, there are so many literatures showing increasing incidence of the female infertility. So between the years 1970 to 2002, the incidence of first childbirth in women over 30 years of age increased by sixfold. Of course, there is a gross difference between these years. When is the what is the age of the particular female while she is planning a pregnancy, while she is delivering a baby? Initially at the age of 24-25, family used to get completed, and now with the women empowerment, the women education, their career, so family start happens at after the age of 30-35. So this has a gross impact, and at the same time there is an overall decline in the fertility because of the changes in the environment, increasing stress trends, and then at the same time changes in the diets, lack of exercise. So overall the lifestyle has changed. So there the fertility potential is decreasing, and here the age at which the female conceive is also increasing. So of course, the proportion of women who remain childless increases with the age at the time, increases with the what as compared to the what is the age at the time of planning a baby. So this was a study where it has been very clearly shown. Now we'll talk about while dealing with this low AMH. Now AMH is a marker of the ovarian reserve, as we very well know. Now we will just briefly see what exactly is ovarian reserve and why so much importance to the AMH, not other markers, and how to deal with that. Now ovarian reserve. So it is the term that is used to determine the capacity of the ovary to provide eggs that are capable of fertilization, resulting in healthy and successful pregnancy. So with advanced maternal age, the number of eggs that can be successfully recruited for a possible pregnancy declines. So this is like a nature's timeline to each female. So this constitutes a major factor giving inverse correlation between the age and the female fertility. So while assessing this ovarian reserve, there are certain points like there are no accurate tools available. The best available test which gives the estimation of already recruited pool of the follicles, not actually the primordial follicular pool. And very commonly measured tests, as we know, serum FSH level, serum AMH level. When we do a transvaginal ultrasound, we do the counting of the follicle, that is antral follicle count. So these are the very few common tests. There are a whole lot of tests, but we'll not go into detail because our topic is not the ovarian reserve per se. That's why we'll concentrate more on the AMH. Now, what is this AMH? So Alfred Jost, who is a French endocrinologist who discovered this AMH, which is anti-Mullerian hormone, that is Mullerian inhibiting substance. It is chemically dimeric glycoprotein hormone, which is belonging to transforming growth factor beta family. And basically it is produced by ovarian granulosa cells. So basically from the granulosa cells of the small antral, pre-antral follicles. And of course, as the age increases, the level of the AMH will go down. And based on the different levels, we have the different categorization in the ovarian reserve that we will see further. Now, what is this AMH? So AMH levels are indicative for the size of the growing follicular pool, and which is considered as a marker of ovarian aging. Now, this AMH declines with the age. Hence, decline in the AMH levels is the earliest marker of the ovarian aging. So this is a very powerful marker which is very commonly used, and just it is, by blood test. So changes in the serum AMH levels occur relatively early in the sequence of events associated with ovarian aging. That's why it is very useful one. And it also has a strong correlation between the, with the AFC, that is antral follicle count, meaning generally when the AFC is good, we will have an AMH in the optimal range. When the AFC decreases, we will have the less values of the AMH. Now, AMH is the marker for ovarian response in the women undergoing treatment of infertility. So it helps us to plan their cycles, as well as it helps, it is not just the quantitative marker, it is also a qualitative marker that we will see further. And that's why it is helpful for predicting even the outcome of IVF procedures. Okay, now, about the role of AMH. So this AMH is produced by, as I said, small growing follicles, that is primary and pre-antral follicles. So basically it inhibits the follicle recruitment. Okay, it inhibits the recruitment and it inhibits the FSH dependent growth and the selection of pre-antral and the small antral follicles. So basically it has been mentioned that AMH conserves the ovarian reserve. Now, as I was talking about, the clinical implications of the how we interpret the AMH, and basically there are different methods of so biochemically in the labs there are different methods by which it is the blood test by which we calculate the values, and it is in the picomole per liters or it is in the nanogram per ml. So generally, in our Indian scenario, we concentrate here on nanogram per ml. So AMH has a different functional ranges, like optimal fertility when the AMH levels are 4 to 6.8 nanogram per ml. So this optimal meaning, this gives a good response to our treatment, and that means it's a good reserve. So people, with respect to the how we correlate with the planning of the treatment, yes, they have time for the simpler methods. They have their own time for planning a pregnancy. Now, satisfactory fertility, second best level, which is now again it is a lower, like 2.2 to 4 nanogram per ml. So this is an average response. Okay, when we can say little, borderline, or where the age of the female is also increasing, and then here how we correlate with respect to the planning. Yes, now they have to be very much vigilant. They have to plan the pregnancy, start planning it. It doesn't mean that they require advanced treatment, but yes, they should be having a proper planning, not to waste time. Now the next level is a lower fertility zone, where the again antral follicle count AFC is low, between say 3 to 5 and all. So where AMH is 0.3 to 2.2 nanogram per ml. So now definitely they require a treatment, especially we can't exactly comment only whether they require IVF or what, because all other depends upon other factors of infertility. It is all interpreted based on the age of the female. So there are different factors, duration of the infertility. So exactly it cannot be, but definitely we can, based on this, we can, predict which methods of fertility treatment would be useful and what would be the prediction of the outcome. And very low or undetected is less than 0.3 nanogram per ml. So generally these they don't have much reserve, and they may not have a good oocyte. These are the candidates generally, I'm talking about generally, require donor eggs. It is never like they will. We cannot use this test to counsel the actual mode of treatment and whether it is a self eggs or a donor eggs, because it's a nature and we cannot underestimate the natural conception anytime. So even a very low AMH, sometimes definitely we have seen the natural conceptions miraculously. But yes, I mean, as I said, it has to be interpreted based on the other backgrounds. Okay, now, so why AMH is the better test for the ovarian reserve? Why so much we give importance to this test only? Because now, basically, as you know, if we go back to the embryology, while the development is going on, especially for the sex organs, the AMH is seen in both the genders, but later on it is the different, especially it will be specifically seen associated with the Sertoli and the granulosa cells. So definitely it will be seen at higher levels in the females. So it has that gender differences, and later on it gets a specificity for the Sertoli and granulosa cells. So it is very specific. Since the AMH is produced continuously in the granulosa cells of the small follicles during the menstrual cycle, this is a very important point. It is superior to the episodically released gonadotropins like FSH, LH, and ovarian steroids like estrogen as a marker of the ovarian reserve. So simply, it doesn't have the inter-cycle variability. So it can be done in any day of the cycle, especially helpful when the people are having, females are having irregular periods, because then we cannot wait all the time for the day 2 or day 3 for the baseline cycle for FSH, LH, and E2. Now next, furthermore, AMH concentrations are unaffected by pregnancy or oral or vaginal estrogen progesterone based contraceptive. So basically, it is a very specific, marker. And so further advantages are, it's a very superior than other markers, and it has mainly the paracrine control. So it is independent of the HPO axis and whatever HPO endocrine feedback. Now it correlates well basically with the AFCs, that is antral follicle count, and other markers like FSH, inhibin B, and E2. And basically it has higher sensitivity and specificity than conventional markers. It remains relatively stable, as we discussed, throughout the menstrual cycle as against FSH, inhibin B, and E2. So thus also it has a lower intercycle. So initial was the intracycle, and now this is the intercycle variability. Okay, and so there are, of course, age-adjusted AMH levels are there for the fertility patients, because the normal range of the AMH will vary based on the age of the patient also. So basically, generally, those are age-adjusted. So as I said, they have to be interpreted based on the age of the patient. And it has been seen that we will see further that AMH with low AMH in the younger age groups, we get a good results. Now, factors modulating AMH levels in the women. So hardly influence or no influence, as we discussed, menstrual cycle day duration, then intra-individual variation, and pregnancy and obesity and other hormones like smoking, alcohol, stress, these won't. Now, decreased serum AMH generally, of course, menopause, obesity, and few things like high TSH levels and other things. And increased AMH, of course, that is different PCOD and increased in the antral follicle count and hyperandrogenism. So that is the different, that is out of scope of this topic today. But yes, so generally, there are very less factors which influence the AMH levels. Now, what is its significance in the ART, that is assisted reproductive technologies? So as I said, because it categorizes the ovarian reserve into normal reserve, borderline or low reserve, and high reserve. So it can be helpful in planning of the cycle. Of course, it can be helpful in prediction of the ovarian response, like hyper response, poor response, or cycle cancellation. And as I said, it is also a number that is quantitative as well as the qualitative, that is quality of the oocyte yield also can be predicted. And other markers, like it also helpful in the prediction of fertilization rate, blastocyst rate, embryoploidies, miscarriage rate, and the live birth. So it is a very useful versatile marker. Now again, AMH and the age. So the implications of low AMH level may vary depending upon a woman's age. So in a younger woman, a low AMH may indicate that it may be more difficult to obtain eggs during the fertility treatment, but it does not necessarily mean that eggs obtained from the treatment will be of a poor quality, meaning a low AMH, as I was discussing, in the younger age group, we get really good results. And that's why this should not be the sole criteria, as I said, to counsel patients for the actual mode of treatment or using self or the donor eggs. That is always the combined other factors to be considered. Now, we talk about the poor ovarian reserve, because like we need to see like how we cope up. So to understand, like when we talk about it's a poor ovarian response or the poor responders. So when especially as we are talking about AMH, normally, of course, it is 2 to 4, as above 2 basically is normal. And then poor responders are AMH less than 1, AFC less than 5, and serum FSH high, that is more than 12 international unit per ml. Now, of course, with the age that again we are coming to that point that with the age, the number of the follicles will go down, and of course the higher proportion of the poor quality oocytes. So age has a very much impact on the outcome, and especially the number and the quality of the eggs. So what happens, how it is correlated, this poor ovarian reserve and the or poor ovarian response and the pregnancy outcome. So what exactly? So this POR, poor ovarian response, leads to poor outcome of the pregnancy. Why this happens? Why we need to know that? Because this basic physiology will help us to understand the strategies, how we deal with that. Okay, so basically there are two factors involved. What it does, so there are here the low reserve, there are there is a decreased level of the intra-ovarian androgens in these patients, and there is an oxidative stress inside due to reactive oxidative species. Now, as we know, when we go back to the basic, when we know the basic follicular genesis, it is nothing like, a magical drug where we can, increase the number of the eggs and the quality of the eggs. We can just, maintain the reserve, and we can basically, deal with these problems, this basic pathophysiology. We cannot, like a hemoglobin from 8 to 10, we cannot increase AMH from 2 to 4. But how to deal with that is while we are dealing with these two basic problems, like how to do because of this decreased intra-ovarian androgen, so how we give the supplement so that this will not interfere with our outcome, or how we reduce the oxidative stress. This is our basic strategy to cope up with these patients. Okay, now, so what it does exactly? So poor ovarian response means it is a decreased quality of the embryos with the advancing age. Then number of the embryos will be less. There's a spontaneous fecundity also goes down with the age. Pregnancy rates will go down. Oocyte number will be less. And of course, the aneuploidy will be more. Okay. Now we'll come back to our physiology, what we have seen. So what is this role of androgen in the follicular maturation? So basically, androgens affect the follicular maturations at earlier stages. So it synergizes the FSH response. So it gives so basically they help, it potentiates the FSH receptor. So it increases the FSH response. So this is like synergistic action with the FSH. Now, again, we come to the oxidative stress and the fertility. Now, what happens? In these patients, there are more free radicals. Okay, free radicals, they function in the microenvironments of the oocytes and the follicular fluid. So when there are more free radicals, so what happens is this change in this microenvironment directly have an impact on the follicular development, ovulation, quality of the oocyte, sperm-oocyte interaction, implantation, and also early embryonic development. Okay, so you can see the normal cells and the ROS, free radicals and cells with the oxidative stress. Okay, so how it damages the oocytes? So basically, physical and chemical stimulation by aging, basically, that increases this reactive oxygen species. Ovulation process also has some reactive oxygen species, which is increasing the oxidative stress in the ovary. And what it does, it increases the follicular atresia, that is apoptosis of the follicles. And so the number of the follicles are going down. The ovarian reserve is going down. Because of course it decreases the quality because there is accelerated aging. And what it does at the level of the mitochondria cellular level, it decreases the mitochondrial activity, decreases the ATP synthesis, and antioxidant activity is also decreased. And of course, there is a more of a chromosomal damage. Okay. So basically why we saw this, because now we will see how to prevent, how we can do better for our patients understanding this physiology. So this is the spectrum, like, we have to have a clinical correlation. We have to give certain supplements. Then we try whether, in these low AMH cases, so one is of course clinical correlation, then give some supplements and try some time depending upon case to case basis whether they have any scope for the simple natural pregnancies, and then whether IVF, and the last resort is the ovum donation. So how we manage this oxidative stress? So more is this, okay? So one is this lifestyle modification, of course, telling them to quit smoking, stop alcohol, weight management, because obesity also plays a role, and these are very much, problems of this changing lifestyle. So basically we have to have a very good lifestyle. So good diet, good proteins, better hydration, and proper exercise. So all this, and then of course, no smoking, no alcohol. So these are lifestyle modifications. We'll go into the antioxidants available. So what are the antioxidants? One is a melatonin, then vitamin C and E supplements, coenzyme Q10, and DHA. So these are the available supplements for these patients. Now we will see about one by one. What is the role of melatonin? Okay, now this melatonin protects granulosa cells, okay, undergoing luteinization from ROS in the follicle. So basically what happens, normally melatonin, which is coming from the pineal gland, okay, it goes into the blood circulation and it acts along with the antioxidants, different antioxidants. I'll not go into much detail, but yes, there it is trying to, reduce the oxidative stress on the granulosa cells. Because otherwise, because of the oxidative stress, there will be decrease, oocyte maturation. There is a luteinization of these granulosa cells, which will reduce the, steroids production from them, especially the progesterone will be decreased in the luteal phase. And of course, there is a poor quality eggs and the oocyte. So both, I mean, the quality of the embryo is also going down. At the same time, there is a less support coming. So definitely it is going to give the infertility. So melatonin prevents that. Now, so this improves the oocyte quality, melatonin, enhances the maturation. It also has a role in the recruitment and the selection of the good follicles. And as we discussed, it has a role in the ovulation and the luteal phase. Now, there are different, studies, and they have been, they have shown that 3 milligram melatonin from the follicular phase of the menstrual cycle, it has given higher rates of good embryos, then good fertilization rate. Maybe some study shows that there is no difference in the pregnancy rate, but higher M2 and fertilization implantation rates. So yes, I mean, it doesn't have much statistical significance, but yes, this is one of the supplements. Now, we'll see the another one, which is coenzyme Q10. So this is very commonly used, even in the male infertility also, we use this very commonly as an antioxidant. Now, what it exactly does? So it's an antioxidant. So it protects the cell from the oxidative stress. And basically it maintains the ATP production in the mitochondria. And as we saw there, because of the oxidative stress, the mitochondrial function mainly gets affected. So this is trying to restore that. So this is trying to restore the normal energy production in the ovary. Now, what are the effects? So how exactly it is trying to improve? So it is improved ovarian response, oocyte quality, ovarian, of course, the oocyte recruitment, basically here, the quality, ovarian response. Then it is reducing the chromosomal abnormalities. And there is a delayed atresia due to aging. It somehow delays the atresia. It significantly increases the number of the ovulated follicles, improved ovulation rate, and increased number of the good cumulus, basically. Generally, what we see embryologically also, when the oocyte, poor quality oocytes will have a very less cumulus. So that is also, so it is improving the cumulus also. Then we'll go to the next, which is DHA. So what is this very, commonly routinely used supplement? Yes, it does work well. With my personal experience also, I can tell. So definitely it gives a good response. So we'll see how it works. So it's a dihydroepiandrosterone, so kind of an androgen. So it is like a most abundant circulating steroid in human. And it is generally secreted by adrenal glands, testes, and the ovaries. It is synthesized basically from the cholesterol. it can be converted into other hormones like estrogen and testosterone. And basically, levels of DHEA in women decline with the age. So this DHEA represents the first compound in a new category of pharmacological agents with potential to rejuvenate ovarian environment. So somehow ovarian rejuvenation. Okay. So now what is this DHEA? So as with the age, okay, there's a decrease in the androgen levels and there is a deteriorated ovarian microenvironment leading to poor quality oocytes. Okay. And basically, what is DHEA through the IGF-1? Okay, it stimulates the mitosis, steroid production, and this prevents all this. It maintains the androgen level and it gives the normal oocyte maturation. So DHEA helps in that. So it has been, thought, not really practically, but yes, it gives a good oocyte recruitment, definitely, and good response. It increases the FSH receptors. So definitely the recruitable pool increases. Ovarian steroidogenesis is improved. It prevents the apoptosis of the granulosa cells. And all these factors lead to increased pregnancy rate. Practically, yes, it does. It does, increase pregnancy rate, and it helps in giving a good response to the, stimulation. That is very much helpful. Like generally 6 to 8 weeks of DHA treatment cycle, pre-IVF cycle really helps a lot. So now DHA supplementation is generally 75 milligram per day is the dose, which is at least 4 months TK, but at least 6 to 8 weeks is, as I said, minimum. Of course, when the duration is more, it gives a good response. And it should be given to women with a poor ovarian reserve or premature ovarian failure. Okay, it improved chances of the natural conceptions also. Yes, and considerable improved outcome in the IUI and IVF. And here, as I said, the decision of the mode of the treatment and other things would be based on the other fertility factors, the duration of the fertility and age of the female. It also gives the better pregnancy rates and outcome. And generally, it is well tolerated. It is safer than other androgens, okay? And because other androgens, higher androgens also, which will lead to the negative impact. So it increases the atresia. So it is not like this androgen will not have, this kind of androgen will not have those side effects. Now, another supplement is the testosterone. We use it as a gel or the patch or the spray. So it is generally in the form of 12.5 milligrams per day. But this has little, there are no specific recommendations on when, how to be used, but generally we use it like 2 to 3 weeks prior to the stimulation, and it is used as one of the adjuvants. Now we'll talk about a little bit of the IVF cycles. So those were the supplements basically, and now we'll go into like how especially all this POR patients, like poor ovarian reserve patients. So ESHRE has given Bologna criteria for this. So 2 out of 3 features to be present. So how do we describe, how we categorize the patients or as a POR? So basically, when the advanced maternal age, like more than 40 years, and any other risk factors for POR, like any ovarian surgeries, then chemotherapy, radiotherapy, any other risk factors. And if a previous history of the poor ovarian response, like less than 3 oocytes with the conventional stimulation protocol, not with the minimal stimulation, and any abnormal reserve test like AFC is less than 5 to 7 or AMH is less than 1.1. So any 2 out of these 3, we will categorize them as a poor ovarian response. Now, in these, as we discussed, adjuvants like growth hormone, androgens like testosterone, gel, spray patch, or DHEAs. Then in the stimulation, adding LH, either recombinant or urinary, addition of estradiol in the luteal phase. Now, this is very simple, and this helps in the synchronize the recruitment of the follicles. So basically, it is started in the luteal phase of the prior cycle, and then definitely it gives the good synchronization, because this estradiol decreases these patients have a high FSH level, and because of the high FSH level, the recruitment at day 2, day 3, what we see is irregular. So there is like no synchronized growth, like some are small, some are big and all that, and that's why here we give this estradiol so that we get the regular size. I mean, it's a proper synchronized recruitment. Also, for the local vascularity, to improve the local vascularity, vasoactive substances are used like arginine, aspirin, sometimes yes, letrozole and glucocorticoid. So these are the adjuvants. Now we'll see, I mean, I don't want to much go into details of this, but yes, there are different stimulation protocols. But in general, I mean, we'll see that at the end, but in general, like GnRH antagonist protocols are preferred because it is, the duration is also smaller, it gives a good response in the POR, and it's easy. I mean, patient's compliance is also very much easy for those protocols. So generally 90% of the time, the GnRH antagonist protocols are used, but sometimes, yes, we do use, if it is not working and if the patient want to, try again the self cycles, then definitely we have used this short agonist where we start GnRH agonist from the day 1, day 2 of the cycle, and then we start like stimulation with the HMG. So here we are using its flare effect. Initial 3 to 5 days, the flare effect of the agonist is being used. So we use the internal FSH LH levels for this. But now, as these people already have the high FSH, nowadays the modification of that is a microdose flare, where we use a GnRH 0.2, 0.1. This works really well. Practically, that I have also used many a times, and it gives a good result. So this is like we start this from day 1, day 2, generally day 2 of the menses, and day 3rd, then we start the stimulation. 0.2 or 0.1 of the GnRH analog leuprorelin lupride, and then we continue it till the day of the trigger. So initial 3 to 4 days, it is acting as a flare effect, and later on it is acting, just suppressing the ovarian, basically internal LH surge to prevent further during the cycle, basically. Now, also there are something called ultra short protocol, where we just use it only for the 3 days. This GnRH agonist is used only for the 3 days. It is okay. I mean, it is used not very commonly. Then it is antagonist, which is routinely used protocol, where at the periods we start this HMG. That means we start the stimulation from day 2, day 3. But here definitely, as we were seeing, the adjuvants like, preparation of the prior cycle in the luteal phase with the estradiol and all works very well, because to give the better synchronization, better regular recruitment of the follicle. And when one of the follicle is of 14 millimeter and E2 is more than 200 to 50, then we start the antagonist till the day of the trigger. So this is like a routine GnRH antagonist protocol. Now another one is a soft protocol. Soft protocol meaning it is like minimal stimulation. So it has been seen that instead of just pushing too much with the gonadotropins, we can, allow little bit natural selection of the follicle. So which is something called a minimal stimulation. So it is used a clomiphene, that means tablet serum, which is used from day 2, that we continue till the day of the trigger. Then after like 4-5 days, then we add basically gonadotropins, and then the antagonist is added as per the need. So here we are not pushing too much. Here we allow the natural selection of the follicles, basically. So this is something minimal stimulation. That's why. So it is like a soft protocol, not a conventional stimulation. Yeah. Now the gonadotropins we use during this. So it is confirmed that increased FSH starting dose does not result in a higher pregnancy rates. So because there is the saturation kinetics of the receptor, so it won't help. And generally, practically speaking, 225, little lower for the poor responders, but generally 300 starting dose, and then a step up would be okay till 450 is the routinely used practical method, which works really well. Just starting beyond 300, 375 would not help a lot. So generally those dosages like 525 or 600 units will not work. Then more recent trials have suggested that HMG may have advantages for poor responders undergoing IVF. So yes, there is a limited data, but definitely it helps because there is a need of ALH in these patients stimulation that we will see how this ALH will help in the response. Also, some people use the mixed protocols like recombinant FSH and HMG. So that has also been very popular. So it provides both higher dosages of the FSH also, and at the same time the LH activity. But that is very true. These patients, we don't have only FSH based protocols. LH is definitely required in the stimulation of this POR patients. Now, what this LH supplement, does. So there also, if you remember a physiology, this LH in the moderate amount, in the high dose of the LH has the ceiling effect. Okay, so this is the LH in the physiological dosage. The higher doses of LH is again detrimental to the follicular development. So basically, this LH supplement here, it increases the FSH receptor, so it increases the responsiveness. Okay, it upregulates the growth factors. It also acts synergistically along with the IGF-1, insulin-like growth factor 1, and it stimulates the theca cells for the androgen production. So androgen after aromatization goes into the estrogen so that it improves the intrafollicular steroidogenesis. And also it has the anti-apoptotic effect on the granular cell. Again, I make it a point in the normal physiological dosages, not the higher dosages. Now, another one is a growth hormone. So yes, what is the role? So it stimulates the ovarian steroidogenesis, it stimulates the follicular development, enhances the ovarian response to the FSH. And these all actions are mediated via IGF-1 that acts in synergy with the FSH, amplifying its effects on the granulosa cell. So basically, it acts with IGF-1 receptors. But again, what are the disadvantages? It's very costly and it is not very commonly available. So, and there are not much consensus for the dosages. So generally 2 international units subcutaneously it is used during the stimulation, but I mean more in the research setting, so not very commonly available. Now again, so this is again, this was up to the stimulation. Okay, so for the final outcome, there are other other strategies also we need to use, like what should be the ideal day of the transfer, and what is the role of day 5 transfer for the poor responder. Okay, it's less clear. So there are again certain papers, again going back to the older times, where the clinical pregnancy rates of the poor responders undergoing day 2 and rather than day 3. So sometimes earlier giving to the uterus embryos, when we are giving back to the uterus early, they definitely give the better results because it's a stress to the embryos outside. So definitely that helps. So this is again individualizing the day of the transfer. It should not be always blanket therapy like yes, freeze all or day 5 transfer. No, it has to be individualized. And to give you an example of our clinic, our setting, where we have done so many day 2 transfers, fresh transfers for the poor responders, giving very good pregnancy rates. Even the patients, those who have had the failures with the freeze all strategies, blastocyst strategies, we have done their fresh transfers, day 2 transfers, we have got the good results. So definitely underlying thing is we have to have the individualized strategies, not the blanket approach at all. And there are other newer modalities, yes, like polytropin alpha, which is the hybrid sustained FSH activity, which is along with the highly purified HMG, HPHMG in the antagonist cycle. So that is also one of the promising protocol which is coming up. And then stem cell therapies, intra-ovarian PRPs, these are all invasive methods and still in the research setting, but they have given pregnancy rates, but it is not yet statistically significant. Numbers are not great in the trials. Then some oocyte activation therapies, gene therapy. So these are all further future things. Gene therapies are especially where there is a FSH receptor polymorphism. So these are newer modalities. So just to come to a conclusion, so what are the take-home points of this discussion? So maintenance of the female fertility. that is proper functioning of the ovary is important. Okay, so to maintain the fertility levels. So ovarian function now. So basically we have to concentrate on the ovarian function, and it all depends on maintenance and the normal development of the follicle, because yes, ovarian follicle is the functional unit of the ovary. And oxidative stress affects both natural as well as the assisted fertility. So here very important how we manage these oxidative stress with help of good antioxidants available. Body weight maintenance, smoking cessation, stopping alcohol, abuse, help restore some ovarian functions. Of course, this is a lifestyle modifications, and there are very good medications available where there are combinations of DHEA, coenzyme Q, then leucine also, like melatonin going to the leucine actual activated form. These are, so we have to make use of these combinations very intelligently. So melatonin, coenzyme Q, DHEAs, vitamin E, C supplements. So definitely it helps to preserve and regain the lost follicular functions, and at the end, good fertility plan. So initially, as I always say, initially our problem was to control the fertility. That is, so that there came a concept of the family planning. But now the concept is of the fertility planning. Plan fertility well. So we have to counsel our patients. So as soon as they come in contact with you, and definitely even if they are not planning a pregnancy, considering their age and all things, AMH assessments has to be done. They have to counsel about, they should know that fertility declines with the age and the current situation of it, and how they can plan, and they can review based on the AMH result. They can review their planning of the fertility. If they want to still delay, they can go for the egg freezings rather than having regrets later. We have seen so many patients having regrets later, and they have had a very difficult time to accept the decision of the donor eggs, because they had the regret that they did not have awareness at right time. So definitely it is, as a doctor, our job to make sure that each and every person, each and every female rather, should understand this fertility, her fertility, and that how much time she has, where she is in that biological clock. So she should know that. So that is very important about it. So I think this was all about today's thing. So thank you so much. And then I suppose I'll ask if there are any questions, so we can take few questions.
Yes, ma'am.
Yeah.
We have a couple of questions.
Yes.
One question is regarding embryo freezing.
Yeah.
So how long can we freeze the embryo? And what would be the time duration to store and again get for the implantation?
Okay. So second question I didn't understand. Sorry. How long?
How long we need to store the embryos?
Yeah.
And what would be the duration from freezing embryos and to implant it to the body again?
Okay. Yes. So see, now freezing embryos. So these embryos are frozen with the this is something called as vitrification technology, that is rapid freezing technology, and it is very fine technology now, and we store it in the liquid nitrogen with minus 196 degrees. So basically it can be frozen for that's a indefinite time, but as per the now you must be aware that there is a ART law. In that, as per the ART Act, now we can freeze the embryos for 10 years of duration, okay, and without affecting any quality of the embryos, provided they are frozen at a grade A stage. And now, as another question was how we prepare. So there is something called frozen embryo transfer cycles. So if we decide to give these embryos back to the body, we need to prepare the endometrium. So there are different protocols for it. Very commonly used is a HRT protocol, that is hormone replacement therapy. That means the estrogen tablets are given generally for the preparation of the endometrium lining. From the day 2 to day 3 of the periods, there are certain supplements like ecosprin, arginine, these vasoactive substances are used, and the endometrium lining is prepared. So generally it will be getting ready by say day 12, day 13, and then based on the age of the embryo, whether it is day 3, day 5, at the time of freezing, we give the progesterone preparation. So generally so 3 days of 5 days of the progesterone and then transfer. So when we decide and we start from say day 2, it takes a 15 days time grossly to give embryos back to the body. And they are thawed only on the day of the transfer, not thaw and freeze thaw. No, on the day of the transfer, they will be taken out, and then they will be put inside the uterus, and 15 days later we get the results.
More question, ma'am. What would be the ideal AFC count to consider an individual for IUI?
Okay, so see, basically considering IUI, which is the basic fertility treatment. So ideally, we would prefer normal AFC, meaning 8 to 10 7 to 8 follicles per ovary. So overall 12 to 13, 14 AFCs. And when it is like more PCOD patients and all, they will generally have more AFCs. But here, to give more into this question, generally AFCs less than 5 to 7, we should not much go for the IUI. Again, as I said, it all depends upon what is the background of, what is the age of the patient, what are other fertility factors. But generally for the IUI sort of treatments, which are the basic treatment where the success rate is also maximum 15 to 20%, we should go with the normal patients with the normal AFCs. Borderline AFCs will further require advanced treatment.
Thank you so much, ma'am. Thank you so much for this in-depth description. I guess even in the comments also, majority of doctors are saying that it is very interesting topic and detailed explanation
really
has been given.
Yes,
it was
my
really
pleasure.
Good, interesting. Even I have learned few things.
Yes, those are simple things. Yes, but then awareness is, I think, more important. Yeah.
Sir, ma'am, can I ask my question?
Please, you can.
In personal, basically, I have AFC of 9 per ovary.
Okay.
So I just wanted a suggestion, how should I go regarding the fertility things?
And what about
I don't have any other comorbidities.
Okay.
I
and
have
age?
25 years, ma'am.
Okay. So I think I think we should check AMH. Have you checked?
I haven't gone for AMH, ma'am.
So better that once we should check for the AMH, because sometimes we have seen such a cases also where AFC is more, but the AMH is less, meaning whatever we see on the ultrasound, all of them may not be active follicles. Okay, so that is also one of the things. And in such a situation, just here then, if the other parameters are normal, if the semen parameters are normal, just then we have to have the basically proper ovulation monitoring. So we should have a follicular monitoring. If there is a regular ovulation, good, you can just monitor that and go for the natural try, of course, because age is good, other factors are fine, then there is no hurry also. But yes, we should also plan well, like we should be understanding when it is not working, okay, and when we should move on to the next level of the treatment. So definitely the AMH will help us in telling that, like, okay, now this is not working. So we should have, like in your case, like 2 to 3 months of the folliculometries, give yourself a proper timing. If not happening, then ovulation induction with the letrozoles, and then 3 to 4 months. If it is not, then maybe further, tubal testings and then the IUI and all if required. But definitely I would suggest to have the AMH, and based on the AMH, we can plan the treatment, flow chart accordingly.
Thank you so much, ma'am. Thank you.
Thank you. Yes. Thank you so much. Thank you for having me here, and happy Diwali to everyone.
Thank you, ma'am.
Okay.
Happy Diwali to you.
Yes. So I can log out now.
We don't have any active questions for now.
Yes. Fine. Thank you.